The reason to avoid a heart and vascular paradigm is there really is no paradigm. There's no set standard for how these things should function. There's certainly no evidence that they benefit patient care. And really what they're set up as a trap, and it's a trap for the downstream financial revenue that's generated by cardiologists, interventional radiologists, CT surgeons, and vascular surgeons. And I think when we scale us to that size, we're going to fail. There are more cardiologists than we are. There is a higher marginal income on most of the CT procedures than we will generate. And so I think when we're put in that center, we're at a complete disadvantage as far as who is going to get those resources. Well, it's number one, it is a financial thing, and that's the whole reason for their existence. So finances have to be considered because there would be no heart and vascular centers if it weren't for finances. But when I look at that, it's not only financial resources, it's educational resources, it's operative resources, it's your equipment to do your procedures, it's time in the cath lab, time in the hybrid suite. You know, that's all going to be allocated through a heart and vascular center. The odds are, as a vascular surgeon, you're not going to be in charge. I wish they could think about it, but they probably won't get a chance to, because most of us are put in heart and vascular centers and don't have a lot to say about it. So by the time the consultants come and you're in the room answering questions, it's a done deal. You're going to a heart and vascular center. If that's what your CEO wants, that's what you're going to get. So then there's all kinds of ways to try to protect yourself. You have to look at the organizational structure, make sure that you have a voice, especially in the care of carotid disease, of PAD, of aneurysmal disease. Make sure that these paradigms and treatment algorithms are in your favor, or at least meet scientific standard. You know, use the SVS guidelines. Make sure that whoever is making those decisions, they will be accountable to you, especially with regard to the diseases that you treat. So the model that the vascular surgeon wants is vascular surgery standing on its own. And whether that means you're going to involve podiatry, plastic surgery, the people we actually work with every day. You know, we share very little in common with cardiologists other than the patients and the tests that we order. But as far as the diseases that we treat and the procedures that we do, I think we share a lot more in common with other things. So there are still opportunities to set up limb salvage centers, aortic centers, in conjunction on a disease-based basis, and I think that would probably be the smartest thing for us to do. Heart and vascular centers have been in place for over 20 years. If there was evidence that they supported patient care and improved outcomes, we would have seen it by now, but we haven't. So vascular surgeons need to look to other ideas rather than these artificial entities as far as improving patient care, like aortic centers, limb salvage centers, and where it's really based around patient treatment rather than keeping all the finances in one center.